I'm here, yes. Good morning.
Okay, we have a little feedback problem, but I think I can hear you.
Well, that's hers. She was in Teams. She was just dropping over to the Zoom.
Okay, James Goon. Becky on spot, you're here. Judith Shun, are you on today?
I am. I'm sorry I couldn't be in person, but I have a 1 o'clock meeting in Michigan that I have to meet at, so gotta be there.
Glad you're here. Kelly Tungate, Kelly, are you on?
Good morning, I am here.
Great, good morning, Kelly. There you go, see you. All right. Deb Lambert, I know, is away at a conference. She will not be here today. Jennifer Lance is
Good morning.
Here. Dan Mustard. Dan, are you on today? Dan in Columbus. Okay, don't believe so. Megan Springer. Megan, are you on this morning? Okay, 6. Okay, well, we do not have a quorum, so what we will do is I'm going to ask you to review the minutes that were sent out. I hope everyone got the minutes.
No.
No? Okay, we will have to ask that the minutes get sent out then.
I did not get them back from Dan.
Okay, we have a little delay on getting minutes back and sent out. So we will get minutes sent out to you. And so we will file our May and July minutes and put them up for approval the next meeting when we have a quorum. Okay, this morning I am delighted that to introduce our new Medicaid director, Cora Steinmetz, and I'm going to ask Cora to come up and tell us a little bit about herself. So glad you're here, Cora.
Thank you so much, Dr. Burke, and thank you for the opportunity to just say hello briefly this morning. I see some familiar faces on the screen, so that's great to see. So thank you. My name is Cora Steinmetz, and I am finishing week 5 in my new role as the Indiana Medicaid Director. Prior to this, I served in Governor Holcomb's office as the Health Policy and Operations Director, where I had responsibility for strategic direction and operations for all of the Health and Human Services agencies. So the Family Social Services Administration. So working closely with my current Medicaid team now, as well as the Department of Insurance, Department of Child Services, the Department of Health, and the Board of Animal Health. My background prior to that, I was in finance and government programs roles at a large hospital system here in the state. I'm an attorney by training, Butler grad, went to IU McKinney for my law degree. So that's a little bit about my background, but I'm just really pleased to be with you today and appreciate the opportunity. No formal agenda here or presentation today, other than to say that one of the big objectives that Secretary Rosiniak laid out for me when I accepted the position as Medicaid Director was to really foster strong relationships with the sister divisions across FSSA in particular. So I'm just really delighted to be working closely with Leslie Huckleberry, our Director of the Division of Aging, Kelly Mitchell, the Director of the Division of Disability and Rehabilitative Services, and Jay Chaudhry, who is our Division of Mental Health and Addiction Director. Of course, across FSSA in our 8 primary care divisions, we have a lot of opportunity to collaborate, but in particular, those areas have strong collaboration and need for alignment with our Medicaid program. So Leslie, Kelly, Jay, and I are all committed to ensuring that we are providing really strong stakeholder engagement with groups like yourselves and really serving Hoosiers well and making sure that we're breaking down silos to really deliver holistic services in the social services space throughout the state. So I really look forward to working with you all, especially as we look at our Indiana Pathways for Aging program. That's an area where we're spending a lot of time, and I am deeply diving in to that work. We have some other top of mind initiatives, if you will, within the Medicaid space that have really been my focus since joining, which in addition to our long-term services and supports reform and the Pathways for Aging program, include our strategic rate matrix work, where we are setting a consistent schedule for updates to all sorts of rates across the Medicaid program and services, to ensure that we are really not going many, many years without looking at a specific service category, and that we're applying inflationary factors as we go to really index those rates and create a transparent, consistent rate setting process. Additionally, we're working closely with the Division of Mental Health and Addiction, as I mentioned, as we look at mental health reform and some of the work around mobile crisis, the certified community behavioral health clinic transition that we are undertaking. Medicaid will be a key funder of that work. And so we look forward to continuing that collaboration. And then, of course, very much ingrained in our work right now is the Medicaid unwind and the return to normal operations following the conclusion of the federal public health emergency. If you're unfamiliar with that, the state is taking a 12-month period by which we are performing Medicaid redeterminations for the first time since the beginning of the pandemic. So as you can imagine, that is a very large undertaking, and we are doing everything we can to ensure that the outreach and communication we are doing for members ensures that everyone who is still eligible for the Medicaid program remains on the program. So just wanted to briefly share a few of our big priorities that we have at the moment and to introduce myself. I appreciate this opportunity. Please feel free to reach out to me. My contact information is pretty well findable online, but it is just cora.steinmetz@fssa.in.gov. I'd love to have the opportunity to answer any specific questions you have, or if there are future topics, we can collaborate on, or you would like to see the Medicaid team integrate into your all's work, we would be more than happy to work with the Division of Aging and this group to do that.
Well, thank you so much, Cora. Hang on a minute. I have a few things to say, and then
Sure.
I want to open it up to people to ask questions.
Wonderful.
We really are pleased to work with you here from the commission side, as we had a little chance to talk before the meeting started. And I said, as we are restructuring some of the services for older people in Indiana, and there's a restructuring going on within FSSA, we work primarily with the Division of Aging. And are we getting feedback? And we need to work closely with your office also. And so we want to be sure we have a good relationship going, and we'll be needing to hear from both divisions as we go forward. I would like to just ask you a question and your approach to this. Hopefully we're moving, as we move toward a vertical integration of healthcare and a more comprehensive approach integrating behavioral health, and I'm going to use the term social care. I think it begins to address these issues. Sitting in your position, I realize you haven't had time to prepare a response to this, but in your position with what I just said, with the integration, the comprehensive, taking traditional healthcare, behavioral health, and social care, and trying to integrate that into a system, you're sitting there with Medicaid trying to deal with that. And I looked at the Medicaid programs in Indiana yesterday and got a headache real quickly. There's a lot of complexity in there.
Yes.
How are we doing? We got two different silos. We got the Indiana Department of Health over here. We got FSSA here. And we got all these aging programs going into managed care. How do you see bringing this together? What response might you have to what I just said?
Thank you for that question. It's a great one. And I'll put my previous hat on just for a minute. In my prior role, I really had the opportunity to see one of the, I hesitate to say this, but one of the positive takeaways that we can bring with us as we come out of the COVID-19 period is that a whole of government response really came together, and we saw great collaboration between our Department of Health, the Family and Social Services Administration, and other health and human service agencies. The role of 211 as they stepped in to respond to the pandemic is a great example of that. So many of those relationships that were forged during that time have continued, and we've been able to build upon them even as staff have turned over or there's been changes in programming and the like. There's some really great opportunities and pathways, no pun intended there, to that were formed during that time, and they're continuing on. With that said, we have a lot of work to do still. One thing that has been an area of learning for our Office of Medicaid Policy and Planning is around, with the transition into managed long-term services and supports and our Indiana Pathways for Aging program, really taking in and soaking in some subject matter expertise around things like service coordination or other areas that are not historically clinical. The Medicaid team has historically been very clinical in the approach, understandably so. That's how many people think of that. But as we look at the Medicaid waiver populations, we've been very thankful to have the opportunity to engage closely with our Division of Disability and Rehabilitative Services and the Division of Aging to really look at whole person care and what does that entail. And of course, physical health and mental health are key components of that, but there's more as we look at it, right? And we think about things like social isolation or access to technology or home modifications and things that really will allow individuals to age in place. We are really excited for our Medicaid team specifically to start thinking about that closely in collaboration with these other areas and recognizing that we have not had that subject matter expertise to date. So how do we bring that into the Medicaid team so that we are really able to make informed decisions and policy accordingly?
Yeah, the health-related social needs they're there now.
Yes.
Being identified. And I wonder how we're going to see that as policies continue, administrative policies and legislative policies proceed here in the state. We have housing issues are huge for affordable housing.
Absolutely.
For adults, well as younger people. Inflation's really been hard on people. And we have some things we don't have in our programs here that I'm sure will rise to the surface, but just wondered where you were with a more comprehensive view as we move along.
Yes, I think we are improving in this space, but we have a lot of work to do. And it's something that our managed care entities are very aware of as well. When we look at 85% of the Medicaid population is currently served by an MCE or a managed care entity. So, and that will increase as we move into the Pathways for Aging program. So their focus on what is sometimes known as social determinants of health or other needs, including things like housing, it's very critical that we are all taking a consistent approach in that regard. And so that's an area that we're continuing to engage with the MCEs on as well from the Medicaid lens, but it's broader than even just the Medicaid population. So thinking about how we can really serve social service agencies as a whole, I think will be really critical in the coming years.
Other commissioners, any other commissioners with comments or questions or?
Joanne, this is Judy. Is there, as a commission, is there anything that we can do to help the Medicaid area?
Thank you for that question. That's a great question. And to be perfectly honest, I am not quite far enough in yet to know what I don't know and the needs that exist. So I will absolutely tuck that away and be sure to stay in close contact with Dr. Burke and Leslie as those potential collaboration opportunities or calls for assistance, calls to action come forward.
Thank you. Good comment. We want to be working with you.
Absolutely.
Other people on the meeting. Any questions for Cora? Comments?
Can I make one more question? We
Go
got
ahead.
quite a few of my clients got letters stating that they were disbarred from Medicaid. Then they got another letter that said, oops, that was a mistake. And now, so what do they have to do? Are they going to be getting another letter that explains what they have to do to get their Medicaid back?
And I apologize. Which organization do you represent?
I own an insurance and investment company.
Oh, okay, great. I'd love to connect with you offline because we have a specific team. My director of eligibility and member services is fantastic and has really been leading the charge on our Medicaid redetermination work. We'd be happy to take a look if you had a sample notice and maybe if there was some confusion, trying to track down what the root cause of that might have been to make sure that we are taking appropriate action. And if there's something we need to do to sort of expedite a correction there, we'd be more than happy to do that. So please
Great.
feel free to get in contact with me or I can find your information as well and reach out.
Thank you.
Dr. Burke, it's Kelly and Cora. Hi, Kelly Tungate from CareForth. I just I sent the chat in there saying, welcome. We're happy to have you on board. Of course, Allison was an amazing leader for OMPP. So you have big shoes to fill and you have no doubts that you'll be able to do that. So we've had great experience working with you and just wanted to welcome you and congratulate you on the new role.
Thank you so much. I echo that sentiment. Allison was very intentional in designing a smooth transition for me, and I am incredibly grateful for that. So I actually left the governor's office about 3 weeks before I became Medicaid director and was able to really work side by side with Allison during that time while she held the role. And then she remained on with FSSA for 3 weeks after that, sort of in an advisory and counsel capacity to me. So she is fantastic and will be sorely missed. One thing that Allison really excelled at is the stakeholder engagement, making herself available. And so want to really recommit to that same sort of activity during my tenure.
Thank you so much.
Thank you very much for your time.
Look, working with you.
Same here. Thank you.
Okay, as we move along on this journey with pathways, we've asked for a general update from the Division of Aging, and it looks like Leslie's coming up to talk with us. Hi, Leslie.
Hello, good morning, everybody. Leslie Huckleberry, Director with FSSA's Division of Aging. So I didn't have a whole lot on my end, but open to questions from folks. I do know we had one follow-up item from the July meeting regarding an issue that Judith Schoon had brought up on facilities that had closed and then continued to rent out space to folks and then bring in home health providers. We did reach out to Judith, got a little bit of additional information. I did connect with the Department of Health's long-term care director. This was not something that she had heard about yet, but is actively engaged and sort of in the wings waiting, because what we really need to take the next step in investigation is an actual location. So we know, like, where exactly is this happening? Can we send a surveyor out to take a look and see what's going on? So reached back out to Judith to try and get that information. So we'll continue to connect back with Judith and get some more specific information so we can continue running that down. My feeling is this is going to end up with the Department of Health as the primary kind of spearheading looking into this, just because this probably will be tied to licensure issues, but we will stay actively engaged and continue to kind of track and monitor so we know what's going on and where different services might be implicated with this too. So that's the status update I have on that. Any questions?
Well, thank you for looking into that. This is because I don't work in the weeds, so I don't know the answer to this, but for the Medicaid waiver providers, I guess I'm looking ahead here, with contracts with managed care entities, if they are seeing housing problems arise such as this, where do they go with those questions? Is that kind of what we're looking at here?
So I think that's a great question. And so they've got a couple of different avenues they could pursue. So one, certainly reaching out to the managed care entity and or the service coordinator or care coordinator for an individual if they see something for a specific individual. If they have a concern about a specific facility or location, Department of Health with their licensure authority is also another resource. Adult Protective Services if they're worried about abuse, neglect, or exploitation. So there are different avenues that they can pursue, and we all work together to sort of make sure the person ends up and the issue ends up where it needs to go.
You know what, and I just term these unlicensed boarding houses, which is kind of what it would be in my view. But the Department of Health doesn't license an entity such as that, I don't think. That's why they're looking into some of this, is that
so there would be a fine line, right? It depends on, I think, what they're operating as and how they're functioning, and are they offering services, and what does that look like, and how are they structured? And I'm certainly not a subject matter expert myself in that, but I think for them, they'll look at, should you be licensed and you're choosing not to be, and you're trying to kind of work around something. If that's the case, there's still probably is some mechanism of oversight for the building and things like that. And then certainly as we find out more about these individuals who are residing in these locations, are their needs getting met, or are there concerns about things like exploitation, like I said, which is when we bring in Adult Protective Services, or maybe connect with their service providers if appropriate, and if the individual consents to that. So it really, some of it's kind of fact specific, which is why I think once we can learn more about a specific location, we can sort of dig into it a little deeper and get a better understanding of what exactly is going on and what that looks like.
I guess if we heard the term companion living, what does that mean? And is that a service? And all of those things need to be.
And I know we've heard, in some spaces, folks who provide some level of residential settings on private pay, and then they can bring in home health providers, because ultimately, home health and HCBS can be provided wherever the person is residing, right? Whatever that looks like. It doesn't have to be a nursing facility or an assisted living facility, or a facility that's being compensated by Medicaid or Medicaid waiver directly. But I think, to your point, keeping in mind there could be loopholes people are trying to exploit. And so that's the kind of thing we just want to be aware of and have some ability to see into that. So I appreciate the commission raising the issue up, so we can kind of look into it further and work with our partners with Department of Health on that too.
Well, two of them have been this is Judy. Two of them have been closed down by Todd Rakita. He took care of that.
Okay.
The third one, I'm still trying to get their address, because they changed their name again. So I have to drive out there and actually get their address, and which isn't going to happen today because I'll be in Michigan the rest of the afternoon. But as soon as I get that, I will get that to you.
Okay, no, that would be great. And if you want to send us even what you have on name or DBA or whatever it is that you do have, and we can see if we can help figure out what exactly they are from our end too. So I don't want to send you on a wild goose chase trying to hunt down a building and all of that. But if you can send us whatever you do have, we can at least try and help look into it and know if we can figure it out, or the surveyors with Department of Health may have some awareness of it too. So.
Okay.
Yeah. Thank you.
Last week I had a couple of calls, and people said to me, well, Indiana offers assisted living through their Medicaid waivers. My understanding was in the settings rule, and this is me again, not working in the weeds, but in the settings rule, we don't have, our waivers provide home services wherever someone lives. Now, what are we calling it? Do we have a definition for assisted living in Indiana that?
Yes, ma'am. Yes, we do. And we do cover assisted living on the aged and disabled waiver. So that is a covered service on the waiver, and we have a service definition, and we have a definition of what is included in that reimbursement rate for assisted living facilities.
And that's different from home-based services?
So you get similar services under both, but the reimbursement rate is just structured a little differently. So assisted living is a per diem that encompasses several services in one, and the assisted living facility facilitates those different services, versus if you're living like in your home, in your residence, you may get a list of services and you may have a couple of providers providing those services.
Now, is assisted living only in those residential care licensed facilities?
I believe so, but I would have to double check on the specific, like what makes an assisted living facility. Yes. Aaron says yes. Yes.
So if a facility, here was the question, if a facility is not licensed as that, can they still say they provide assisted living if what's going on is that people are renting an apartment and they're getting home-based services?
So I know there are a handful of
what I'm asking.
I think so. And there are a handful of like unlicensed. Do you want to talk about that? But yes, I'll have Aaron.
Sorry, I just like we better, this needs.
So to be certified as a Medicaid waiver provider for assisted living, you have to be a licensed residential care facility through the Department of Health. Unlicensed facilities cannot provide assisted living services on the waiver. However, unlicensed facilities can register if they call themselves assisted living. They're supposed to fill out a disclosure for housing with services establishments with the Division of Aging. So they do fill out this disclosure form, but they cannot be a waiver provider.
Can
for
they
assisted
call
living.
What they provide assisted living?
They can call it assisted living, yes, but they can't be a waiver provider. They can bring waiver services in because it's, as Leslie mentioned, wherever people are.
So trying to explain this to the general public is very difficult. Yeah. So it's on their websites that they provide assisted living, but it's really not assisted living through a waiver. That's what I got the calls on. I said, yes, they are. I said, don't think so, but they provide it, and it's on their website. So it's just, how do you explain this to people? I'm not, it's complex.
Yes.
I don't know if we need clarification or not. And I got calls and people said, yes, we can get Medicaid waivers for assisted living here. And I thought, I don't think that's what the waiver's paying for. Yeah. Okay, so it's being done, it's kind of be out there, it's a little fuzzy.
Yeah, and that is a statutory function, right? So it is in state law. Yes, thank you, Erin. She has all the knowledge in her brain, so I'm very grateful for her. I think delineating by available payment method, right? So they can call themselves assisted living, but if someone calls them up and says, I'm on the waiver and I want assisted living, then they should be telling folks, oh no, we don't accept the waiver for payment, we're private pay only, or whatever that might look like for them. But it is a complicated system. I agree. Is
that going to get people going on as we transition to managed care? Is that going to be any issue for anybody? Because I guess it will be if you're in a place where you rented an apartment. What if your managed care entity doesn't have that provider in their network? I guess people will have to move, won't they? They must certain.
Theoretically, right? I mean, the provider would need to be in network for them with a managed care entity. The managed care entities are tasked with network adequacy and recruiting and retaining providers. And so that is not necessarily my area on what that continuity plan looks like for go live, but we could certainly have someone come in to the November meeting and talk a little bit about what that provider network building is looking like on the MCE side and what requirements we have in our scopes of work, if that would be helpful.
Yeah, I say that because I know at least the calls I got regarding this was, you know, they call the AAA and want somebody eligible immediately for Medicaid so they can fill their rooms and so forth. And I thought, well, how's this going to work when we get into managed care? It's going to get a little more complicated, isn't it?
Well, on the issue you're talking about on unlicensed versus licensed assisted living, really no more so than it is today, because you're either a waiver provider or you're not. And sort of in the future, they're still not waiver providers. They can't enroll with an MCE because they're not a waiver provider. So that same line will still exist. But again, I mean, to your point, I mean, it's complicated. And I think a lot of folks won't know, well, it says assisted living, but not this type of assisted living, right? Not covered by this particular program.
Okay.
Yeah.
All right. You kind of, I guess I was right. I didn't know if I was or not. And I thought, well, I'm not the only one with questions, or I wouldn't have had calls from people. So, okay, well, that just rests there then. And the other question I had again was around housing and group homes, and Indiana chose not to put group homes into the waiver. Am I right?
Correct. We do not have group home. We have supportive group living in our, at least one of the waivers managed by the Division of Disability and Rehabilitative Services. I think it's their FSW waiver, but I would have to confirm with them. So we do have it for the IDDD population. It is an available service. We do not have it in the aged and disabled waiver. It is not in our upcoming waiver amendment. It's not something that we're including in that. We are in the process of doing a housing study with IHCDA regarding senior housing across the state to identify where those gaps exist, and then think about kind of future state and recommendations and what we can look to help fill those gaps and address the housing need for older adults in Indiana.
And you probably have addressed this before, but I'm going to just ask for clarification. It was another call I had. So when people who are in supportive living get older, 60, 65, what happens? Do they continue with the waiver they're on for supportive living?
So if you mean if they're on one of those DDRS waivers receiving services, so there's no age limit that I'm aware of for their waivers. They will continue on that waiver as long as they're eligible for that waiver. If they're on the A&D waiver, that's where at age 60, they would transition over to pathways, but that's not impacting the DDRS waivers, the FSW and CAA waivers.
So they will not be impacted by the change to
Correct.
Managed care.
Correct.
Anybody else with questions?
Leslie, this is Judy. I have a question for you, and this might be too specific for you here in the meeting, but I have a client who she's setting up an estate for her child who is autistic. And what she's doing is she's donating the home to a group home so he can stay in his home. So when he passes away, they take possession of it and they make it a group home. How is that? How is he going to be affected?
So that is an interesting question, because I think what you're getting into is some Medicaid eligibility and Medicaid estate planning. And again, maybe on the waivers operated by DDRS. I mean, I'm not aware of anything in pathways that would impact that structure. And that sounds like something that's sort of, that sounds more like a DDRS waiver. So they wouldn't be impacted to my knowledge, but you're more than welcome to send the specific case to me and we can look into it internally, and I can check with our team members with DDRS and with Medicaid eligibility and see if there's any nuances there that that we'd want to look into or provide any guidance on further with that.
That's great. Thank you. Because I don't want her doing this if this is going to not help.
Yeah.
Thank you.
Yeah, you're welcome.
Darcy Tower did send an email thanking some of the people here that participated in the program where they're trying to mark, or I guess they're calling it marketing. I don't know. I never know about that word, but anyway, trying to get messaging out to the state about the Pathways program. So some of the questions I raised was kind of related to some of that. We appreciate the opportunity to continue to try to help clarify these rather complex programs so that people can understand what they are and how to access and utilize them. It is hard, especially when you have language that's used in various ways on various programs. So we appreciate the opportunity to participate in some of this, but wow, it's a big lift. Okay, anything else for Leslie?
Leslie, it's Kelly Tungate. I apologize. I didn't know if you had anything else that you intended to share, any other updates?
I do not, but if you
Okay.
have questions on anything, I'm happy to.
I just wondered if you wouldn't mind sharing some updates with the commission regarding the end of the public health emergency flexibilities that will be happening in mid-November.
Sure. So as hopefully you all know, the federal public health emergency ended in May 2023. The federal government allowed for a 6-month unwind period for flexibilities that we had implemented for Medicaid waivers. So both Division of Aging and DDRS, we had implemented various flexibilities under what was called Appendix K authority. And so we have a 6-month period to wind those down. Anything that we didn't decide to make permanent in our existing waivers. So we did post FAQs on our website to provide clarity on here was the flexibility, here's when it's ending, or here's what we did to make it permanent. So those are available for folks that have questions about specific services. We did, an analysis on different services on the number of folks that would be impacted, things like that. So a couple of things we did make permanent in our waivers. A lot of things we either couldn't or didn't feel it was appropriate to make permanent in the waiver. Some of that in consultation with DDRS and OMPP, since the waiver is transitioning next year. So there are those FAQ documents available. Happy to take questions back and kind of address specific circumstances if folks take a look at those and have particular items that they have questions on for that too.
I just thought it would be important, a couple of topics. One is the return to homes, which will be impactful in a positive way, I think, for the families who perhaps are working with area agencies on aging where there haven't been home visits, those types of things. So if you wouldn't mind just kind of speaking to that, because it'll be the first time in 3 years where there really is the return to mandate of quarterly home visits.
Yes. So during the PHE, we had a lot of flexibility for virtual visits for a variety of things, including quarterly home visits. And so the language in our waiver talks about face-to-face visits. And we did clarify with CMS that means actual face-to-face, that's not FaceTime face-to-face. So in areas in our waiver, like quarterly home visits, where it says those need to be a face-to-face visit, things like that are pivoting back to actually being in the home and face-to-face again, which agree that provides, I think, that really helpful touch point to seeing folks in their homes, in their environment, in their community to help continuously assess their needs and just be aware of what services and supports might be available to them that they're not accessing or maybe not getting the full benefit from that they could. So that's one flexibility that we'll be winding down.
And then the other thing that I know we've spoken about at the commission that we've had presentations on is the expedited waiver eligibility. And we did in fact talk about that during the last Commission on Aging meeting, I believe. And Leslie, thank you for your response that we will be moving to a place where the AAAs are managing all of those expedited waiver eligibilities. And you had mentioned that the state was doing some training there, that all AAAs would be participating. So I just wondered if you could share an update on the training of expedited waiver eligibility and whether all AAAs in fact will be participating in that.
Yes, thank you. So as we spoke about in July, we did get approval in our permanent A&D waiver to have expedited waiver eligibility process as part of our permanent waiver process, which is very exciting. We are the first state in the country to get that in our permanent 1915C waiver. We are still working through some systems requirements that CMS indicated we needed to build in at a different spot in our process in order to kind of expand into the permanent place. So we're trying to finalize our plan for that. The training we are working on finalizing as well. So we do have several AAAs that have been doing the EWE pilot from the get-go. And it's really all the AAAs that are in kind of our higher populated areas. So the vast majority of EWE applications were being completed by the AAAs on the pilot already. So we do have a handful of AAAs, more so that have a larger rural population. So they'll probably have a smaller population that they'll see for EWE, but still important to make sure that they are trained and we're having a consistent experience across the state. So we're working to get that training finalized, do a refresher training for the AAAs that have been engaging in this, just because it's been a while since we've given training to those existing EWE entities, train the new ones, and then hope to do things like pair up AAAs, you know, the newer ones with maybe ones that are more established in that process, so they can have some peer-to-peer support as well. And then we'll kind of continue to engage regularly. And we do have, you know, data we're monitoring, building up a data dashboard. So we have kind of as much real-time view as we can into how that function is operating, and hoping to get all of that together here in the coming weeks. So it is very exciting. Still lots of work we're continuing to do and will continue to do to support that new initiative. But thank you for bringing that.
Yeah, of course. And will that data dashboard, that's exciting as well. So that will provide the DOA some insights into those timelines for assessments and start of Medicaid and start of waiver services.
It will. So that will be focused on the expedited waiver eligibility timelines. We are also just generally looking at eligibility timelines. Obviously, we've looked at it a lot, you know, we continue to look at it. That's not something new, but what we are doing is establishing a work group, and several of the AAAs have stepped forward and volunteered to participate to really look at our eligibility processes for the waiver in general as well, and see, you know, where are those abrasion points, what can we do to address some of those and create a more consistent process across the state as well. So on the sort of other side of eligibility, not EWE, we're also continuing to do some work to do what we can to support the AAAs as they kind of go through those processes as well.
Thank you so much.
Thank you, Kelly. One other question I would have, the contracts that have gone out to the MCEs, is that completed? Do we have?
So we've recommended for award, or there are 4 entities recommended for award. We don't sign those contracts until they get through readiness review, which is a multi-month process, and they're in the middle of that right now. So we really tell them, you have to show us you can do this work and you can do it in the way that we require before we sign a contract with you. They're essentially sort of working at risk right now to build this up and show us that they can do what they said they're supposed to do. So those contracts will be signed at some point later next year, I believe.
But we have 4, we still have 4 in play?
Correct.
Just clarify.
Yep.
So Leslie,
go ahead, Kelly.
I was just going to ask the timeline. So that's the contracting with the health plans, but the health plans should begin contracting with HCBS providers in the very near future. Is that correct?
Correct.
Near future, can you help me understand that a little bit better?
Yes, I'm happy to.
Yeah.
Great question. Across the board, the 4 MCEs, after they receive their final approval of their contract and sort of any communications associated with their contract and networking processes for HCBS providers as well as other provider types, they are cleared to go ahead and begin that contracting. Many of them have specific provider categories that have already been approved and may be reaching out to providers currently to do that contracting. The remaining categories are within the next few weeks of approval. So we should certainly see by mid-October some really heavy contracting activity in the HCBS space, as well as other provider types, including nursing facilities, hospitals, the like.
Thank you.
I've come across a couple small rural providers who are very recently became a provider for Medicaid waivers. but I didn't get the idea that they really were understanding how to go about these contracts. So are all current providers receiving funding through Medicaid waivers going to get information about how to continue, or how does that work?
We have been doing a series of provider webinars and information sharing in that regard. I think I have heard that there's still some work to do and that there's varying levels of sort of understanding of that information across different provider categories. So we're continuing to do that work. If providers have specific questions, we are more than happy to do a deep dive or like specific one-off conversations. Darcy Tower is really leading this work on behalf of the Medicaid team. And I think she is a great resource, really knowledgeable in this space to be able to work if individual providers have specific questions or are running into problems with the MCEs. We want to know about that and are happy to help troubleshoot.
And then kind of along those lines, transportation providers. That's an issue in rural areas. So are those transportation providers, they're contractors, they're two, and I don't know, I don't understand the Medicaid transportation, what's going on right now. What's going to happen with that as we go forward with these 4 commercial health insurance companies?
It's a similar approach, I believe, as with the HCBS providers, which is doing the contracting processes. But let me get you some specific information because transportation is slightly unique and I don't want to misspeak as far as what's carved out, what's carved in as we do the transition to managed care.
Okay. All right, thank you.
Just to clarify, the contracts will be out in a couple of weeks. The provider, as a provider network, will be signed with the MCs, but you're saying that ultimately you may not sign with the MCs at the end of readiness review.
I mean, they have to pass readiness in order for us to sign the contract with them. And I mean, our hope certainly is that all 4 get there and we've built out a really robust readiness review plan and structure. But they have to show us they can do the work before they
So
can.
is there something in the contracts we'll be signing that indicates if they don't make it through, we're exempt out of a contract with them?
I have not seen the contracts for the providers myself, but I would just.
My understanding would be if we were in a scenario where an NC was not going to enter into a contract with the state, it would not be participating in the program, the contract would not, be valid still, but we could follow up on that specific question as well as the transportation one.
Thanks.
Did everybody virtually hear that response?
Oh, I'm sorry.
Okay.
Yes.
Okay.
Yes.
If for some reason one of the companies does not make it, are you guys going to try and fill that position yet?
I'm sorry, could you repeat the question?
If for some reason one of the companies does not make it, one of the MCEs does not make it, are you going to try and find a different company to fit in that 4th spot?
I do not want to speculate on that personally. So, I don't know exactly what that would look like. I would assume not. I mean, we have 4 and 3 is certainly robust as well, but I don't think we could answer that definitively until we knew what and when and where and what that looked like exactly.
Okay. Well, thank you very much.
Thank
We
you.
always have questions on these.
Yep, I appreciate it. Thank you,
As
guys.
we're in this journey, and it is a journey. Thank you very much, Leslie. Okay, wow. Now moving on to another area has a lot of activity in it and needs to have a lot of activity in it. We have Sharon Effler with us, who's Director of Geriatric Programs at IU School of Medicine. She's going to give us the update on Indiana's strategic plan for dementia.
Yes, hello, good morning. Thanks for having me today. Before I get started, I want to ask, we've invited all of our dementia strategic plan steering committee members to participate today to really display that this is not just me and the Division of Aging doing this work, but it's a lot of great people volunteering their time. So if you're not already on camera and you're part of the dementia strategic plan, if you could go ahead and get on camera and just wave. You can see some of them. There we go. Thank you, guys. Okay, Rebecca, next slide. Okay, so what I serve as the Dementia Strategic Plan Coordinator, which means I'm responsible for coordinating Indiana's Dementia Strategic Plan. And my predecessor, Dawn Butler, partnered right with the Division of Aging to really get this work going. And a priority in this work is stakeholder engagement. And so I'll talk a little bit about the structure in a minute. And by inviting the steering committee members, I just want to emphasize how many people are engaged in this work and super excited about the impact that it can have. But who am I? You probably know me, right? I was the Director of Care Programs for Indiana Medicaid. I was the Indiana Pathways for Aging Director and Hoosier Care Connect Director. And prior to that in Indiana, I worked at the Regan Streif Institute at the IU Center for Aging Research. I have 15 plus years of aging and end of life experience. It's my passion. I feel extremely honored to be Indiana's Dementia Strategic Plan Coordinator. In my new role, which I started a couple months ago, I am the Director of Geriatric Programs at IU Geriatrics, which is housed within the Division of Internal Medicine and Geriatrics. Next slide. Okay, so just to remind you of what is the overall goal of the Dementia Strategic Plan, it is to identify and significantly reduce the prevalence of dementia in Indiana. This work really began in 2019, where the Division of Aging launched the Dementia Care Initiative that evolved into legislation and is now codified in Indiana code. And that's where we're at right now. I'll talk a lot about 2023, the year 2023 being phase one of everything that's now in legislation we're calling objectives. And we're digging into identifying under each of those objectives, what are we actually recommending needs to get done? Or what are we recommending we need resources for in Indiana to get it done? Okay, next slide. So what's the structure? The Division of Aging is leading this work. I'm contracted with the Division of Aging to help with it. I work closely with Amy Rapp, who's here, and all of the Division of Aging leadership. We have a steering committee. Those are the folks that I invited here today. The majority of the steering committee leads a work group. So when I talk about the objectives that are in legislation, we divided those up into 4 different work groups, and we have a lead that is assigned to each of them, and you'll hear more from them in a minute. But those are HCBS access, workforce, public awareness, and quality of care. In addition to leadership, the steering committee, we also have a very large advisory board. Last year, 2022, in October, there was the first advisory board meeting where we brought, of course, prior to my time, right? But Amy and Dawn brought together everyone who serves on a work group. And there are also some additional people that really didn't have the capacity to serve on a work group, but wanted to be part of the advisory board. And that's one of my asks of you today, is to give us guidance and insight on, are we missing anyone as we enter into the next phase, phase 2, that will start in 2024. So I'll get there in a minute. But that's really a time where we come together and we talk about what did we accomplish and where do we go from here. Next slide. So again, thank you to all the steering committee members, whether they're online today or not, but I wanted you to see who they are. We have a broad representation from different entities, but this is also, open for discussion. If you felt like the smaller leadership steering committee, that there are very important organizations that might be missing, to please offer that to us to consider today. So I'll let you look at that. And we'll move to the next slide. So what is the DSP, as we fondly call it, the status? So we have a deliverable every year that by December 1st, we submit a report to legislators. Obviously, there's a process. There's many steps that go into that leading up to it. One being these recommendations that are tied to each of the work groups. So the work group leads have been working with their work groups over the past year to identify recommendations that we're going to be putting into this year's report. Those are due from the work group leads next week. Then Amy and I will start digesting all of that and synthesizing it. I'm really excited to say there's a lot of overlap. There's a lot of interconnectedness amongst the different work groups. So we're bringing that all together to really present a clear and concise product to legislators. Once we draft it, then DA leadership, Leslie will most likely be on maternity leave at that time. So Andrew Bean will be reviewing it. Gus within FSSA will also review it, and then it will get submitted to legislators. And they may have questions for us, right? They may come back and say, what do you mean by this? Or, you know, I don't know that we can do that. There could be some dialogue. We're hoping for that. And we're also thinking now about ways to help create a foundation where we can get more dialogue with legislators about the work that we're doing. And then I mentioned that we have our annual meeting. We scheduled that for this year in November, and invitations have been sent out for that. And again, we can add more people based on the conversation today. And then initial conversations, we've been talking about having a kickoff in early 2024, where we again come back together and we say, all right, we now know what we're recommending for, you know, what came out of phase 1, and now how are we gonna get it done? Which you all know is the hardest part, right? We can come up with the greatest recommendations ever, but how are we gonna get it done? And if you know me, I'm all about that. So in 2024, I'm excited. Hopefully we can get most people together in person and really have some great time together to dig into that and come up with an action plan for how we get things done. Okay, next slide. All right, so I've asked each of those 4 work group leads to speak with you today about, because we're obviously not ready to present out the recommendations for 2023. I hope you all will have me back in early 2024 and I can share those with you. But I thought it would be nice for you to just glean some insight into what's been happening. So to do that, I asked each work group lead to share a pitch, a peach and a pit with you. So if you don't know what that means, it means what have you really enjoyed about the process of the DSP steering committee and the work that we've been doing. And the pit is what's been challenging for you. What are you coming up against that is hard for you? And then finally, what are you looking forward to? So I'd love for each of them to share that with you, and I'll turn it over to Dr. Elman.
Good morning. I'm wearing 2 hats today with my work on the Commission of Aging and the task force here as well. So the peach that I identified is the dedication and commitment among colleagues across the state working in this space to improve the lives of people living with dementia. The pit is the nationwide workforce challenges that we see not only in dementia care, but also in all of healthcare. And then I'm looking forward to continued innovation in Indiana. Thank you, Shannon.
Thank you. Next slide. So we have Matt. Is he on? Okay, I'll go ahead and present for quality of care. So the goal of quality of care work group is to identify strategies to enhance the quality of care for individuals with dementia. So this has been led by Dr. Unrow, who's on vacation right now, and then Matt Nesvet, who are both tied to the IU Center for Aging Research. And I may have to come up here to read it. Okay, can you hear me? Okay.
Yes.
Okay,
Yes.
Awesome. So they have enjoyed learning from others on the steering committee as we see the the progress the other working groups have made. We're learning from their insights and drawing on these to develop our group's insights and contributions. Their pitch was that one thing they've been challenged to do is to first understand how our work group aligns with other work groups, so we can complement, not overlap others' tasks. And what are they looking forward to? Actionable insights, the novel data sources, and potential analyses tied to pathways will reveal. So Indiana Pathways for Aging is what they're referring to, and about how we can best support persons with ADRD and caregivers. Next slide. I'll turn it over to Dr. Council.
Good morning. Thank you, Shannon. Yes, I've been working with the Home and Community-Based Services Access Group around people being able to access dementia capable or specific or specialized programs for people living with dementia and their caregivers. And very exciting endeavors here, and share a lot of the peaches with the other groups in terms of we've got a very engaged folks who care a lot about this. I'm happy to say that access, at least this number of services in Indiana that can support people with dementia and their caregivers are pretty broad. Our issue is, however, more around services that are specific and dementia capable. And so there's a lot of services to support people, but most of them do not have, dementia expert or informed care processes as much as we could see. The other gap is that is caregiver supports. And so these two things kind of go together for my peaches, that over the past year, we've had, many of you are aware, made presentations before, we've had a 3-year grant from the Administration for Community Living to provide with the area agencies on aging out of IU, a caregiver support program. And we just finished that grant at the end of July, and we were able to serve through that program over 500 caregivers and their loved ones with dementia. And we saw tremendous results in terms of decreasing dementia symptoms, behavioral issues in those people served, and decreasing caregiver stress. So that's been a very exciting project. And then also the work with the Medicare health plans, the Medicare Advantage dual special needs plans. You've also heard about that from me over the past year with our work specifically around identifying people with a diagnosis of dementia. So those health plan members who have a diagnosis of dementia, we are requiring under the state contract with the Medicare plans for them to make a proactive referral to the area agencies on aging of anyone with dementia and their caregivers to help them be more aware and informed and connect and access services that might be helpful to them in the community. I didn't really come up with any pits, so I'll go on to what I'm looking forward to, and many of this is a continuation. So the Administration for Community Living grant finished in July, but the state, due to the success of the program, has funded it for the next 18 months, starting in October. And so not only will we continue to work with the 5 area agencies on aging that were involved in the original Administration for Community Living grant, but we will expand to an additional 5 area agencies on aging. So we'll have 10 planning and service areas involved across the state of the 16 involved in providing the caregiver support program that we developed and really demonstrated tremendous results under the prior grant. And then secondly, similar with Medicare health plans, we'll have the opportunity, I've been a part of the readiness process with the Pathways programs. And specific programming has been built into Pathways around dementia care and support of caregivers. So that will be another very exciting mode of greater access.
Is there a CSNP for dementia in Indiana?
Yes, a CSNP, good question. There are 3 different kinds of special needs plans, or SNPs, and the dual eligible special needs plan is the ones that we've been working with and that require a state contract. The CSNPs are chronic condition special needs plans, and I'm not aware that there's one specifically for the chronic condition of Alzheimer's disease in Indiana. I think we have one around end-stage renal disease. The third, for those curious, is the institutional special needs plans, primarily focused for those who are long-stay nursing home residents. But the final thing that I'm looking forward to, and our Access work group is looking forward to, is seeing the role of the Area Agency on Aging Dementia Care Specialists through House Bill 1422. So this is new legislated activity here beginning in the next year in particular, that's already with planning underway, that each Area Agency on Aging will have a dementia care specialist who's responsible for helping people connect and access services across the state for dementia, of people living with dementia and their caregivers. They'll also be responsible for training Area Agency on Aging staff around dementia, and so helping make the services that we have available more dementia friendly or capable. As I was mentioning earlier, is a gap currently. And then finally, the dementia care specialists are responsible for helping better interface the social services with healthcare, health plans, hospitals, healthcare professionals. So this will be a great boost, I think, across the state for a more systematic access to services for people with dementia and their caregivers. I've taken enough time. Thank you.
Thank you. I did see something pop up in the chat, but I'm unable to view it. I don't know if it's a question.
Shannon, it was from Andrew saying that there is not currently a CSNP in Indiana for dementia or Alzheimer's.
Oh, thank you, Kathy.
I'm sorry, this is Judy. You know what? As specific as dementia is, have they ever thought about doing it? I mean, everything that you just mentioned would be so much better if they had a CSNP that was directed just to dementia.
Yeah, the CSNP is a Medicare plan, so a Medicare managed care plan could specifically, apply to CMS to get that opportunity to enroll just people with a diagnosis of Alzheimer's disease. People under Medicare all have choice, and currently about half of people in Indiana who are in Medicare beneficiaries are signed up for a Medicare plan, but the other half are not. I can't tell you the business case for an Alzheimer's disease CSNP, but it might, it could certainly benefit people if it provided a very focused, sort of package around that problem. I agree with you.
Thank you. All right. You have a question, Dr. Burke?
I do have a question. So the 18 months, how's that being funded in Indiana, the 18-month extension for dementia care specialists? Is that state funded? It's not an ACL. Is that correct?
Yes, thanks. It's exactly. The ACL grant was for $1.3 million, got us over 3 years to involve 5 area agencies on aging with dementia care coaches to support and train their caregivers. So the new grant from the state is using the home and community-based services expansion or funding which originated out of the COVID spends to advance and expand home and community-based services. So this is a new caregiver-specific supports for caregivers around dementia is pretty limited in Indiana. And so this is filling a gap there in terms of helping people access, and specifically caregivers access, this kind of training and support. So it'll be funded state only. That's $2 million over the 18 months using the HCBS spend plan. And Leslie Huckleberry could maybe give you more specifics if you want.
Yes, so it's the HCBS funds, the enhanced federal match that we received as an agency. We're using some of those funds to fund the ABC community grant for the remainder of the timeline. We can use those funds. So
and
about
the
18
Division
months.
of Aging's administering it?
Correct.
Okay. So
well, when the Division of Aging is granting it to IU and Dr. Council to sort of continue on that pilot program and expand it a bit too.
okay, all right, that explains a little bit. Now, as this moves forward into proposed legislation, it's drafted into that, I think, as we move forward here, we're looking at state funding to fund these dementia specialists and AAAs.
So there's two different initiatives that you might be talking about. There's the ABC Community Grant, which is the pilot program that IU has been operating. The Dementia Care Specialist program is separate. That is a new program that we received appropriation for this biennium budget to be administered through all of the AAAs, and it's for education and outreach around the state for dementia services and supports available to individuals with dementia and their caregivers. That was a state-only fund that was appropriated to Division of Aging. We will be administering that out through all of the AAAs through a contract with the AAAs, which we are still working on.
So that's not, that is or isn't that 18 months?
That is 2 years. That's the biennium. So through July 2025. Yes.
Okay. So what's going, so is the ABC program being proposed for legislation to be ongoing?
We're not there yet, honestly. I mean, I think that some of what will come out of some of these recommendations. So for now, it's a continuation of a pilot for the next 18 months. Okay. And we have funding for it for the next 18 months. So future state, I think, is still being determined.
Okay. Okay. So we're walking the walk. Okay.
Mm-hmm.
Yes, ABC Community is what we've now named the Administration for Community Living project. ABC is Aging Brain Care, ABC Community. And so we're very excited to have this state funding to not only sustain what's been happening so well at the 5 current area agencies on aging, but then to expand it to the other 5 additional sites. But a very specific program around providing direct training and support to caregivers, whereas the dementia care specialists have a much broader role.
Thank you.
Thank you all for the great dialogue. Next slide, and I'll turn it over to Natalie.
Good morning, everyone. I'm Natalie Sutton. In my day job, I serve as the Executive Director for the Alzheimer's Association Greater Indiana chapter, and I volunteer with the State Strategic Plan as a member of the Steering Committee and the leader of the Public Awareness Work Group. And my pitch for this year was really just, I can't convey enough, and this is similar to Katie's perspective, but how many incredible people who are passionate about serving those with dementia and their caregivers in our state have come together through this project. And in particular, our public awareness work group was a group of really passionate people. And we had a lot of robust discussion in our every other month meetings throughout the year. So that was a highlight. On a contrary note, my pit this year is that I think through our discussions and given the charge of our work group, which is certainly to focus on public awareness, but also to do some healthcare provider education around early detection and diagnosis. I felt that our work group lacked some of the expertise that we need, particularly for the healthcare provider education piece. We didn't have any healthcare providers on our work group. We tended to be a group of kind of nonprofit social services professionals who are passionate about this issue. And then I think also we focused a lot just based on the people around the table on some of the current state and a lot of the pain points that we experience. And, you know, I really think we need to think more broadly, comparing this to other disease states, looking at moving detection and diagnosis into a much earlier phase to go along with where the science is headed regarding the benefits of early detection. So we could also really use some public health expertise and some participation from the Department of Health in this work group. So I'm looking forward most to publishing these recommendations. I think when you publish recommendations in writing, that comes with some accountability. And I think in publishing those, we'll be able to bring some additional expertise to our work group and to the execution process. That's all from me.
Yes, thank you. All right, next slide. All right, so where do we go from here? There was a little bit of talk about the dementia care specialist program, right, with the AAAs. That is very connected to this work, but what we're talking about today is purely the coordination of the work, and the DA is in the process of developing the dementia care specialist program, which includes a full-time position within the Division of Aging who will lead that work, okay? But that's on the horizon and is huge. I mean, that's huge. When I think about that program, I mean, I'm very, very excited. It's gonna have a huge impact. As we enter phase 2, I talked about we're going to have a kickoff in early 2024 where we're hoping to bring everyone together and really get into the nitty-gritty of how do we get this done. And as I mentioned, I'd love for you to have me back so I can talk about what our 2023 recommendations are and get your feedback on those. And then finally, we welcome input on any additional organizations that you feel should either participate in our large advisory board or the steering committee. So if we could go to the next slide, which I now realize may be more difficult to see, but these are all of the amazing organizations that are participating in our advisory board and our steering committee. So what I would, oh, thank you so much, Rebecca. I do also want to underscore that most of these individuals are volunteering their time. They're not getting paid to do this work. This really is grassroots and across the state, people coming together and acknowledging how important this is and that it's going to take all of us to get it done. So rather than reading it to you, if you wouldn't mind just taking a minute to look at it, and if you have any additional suggestions to let us know. As Natalie mentioned, we will be working to secure some more direct healthcare providers on our team. So that's an area, but anyone else?
Well, this is one of those areas where I kind of started this morning talking about integration of traditional healthcare, behavioral health, social care. Boy, this is one that comes up that says we have work to do. It's just always, I think I say this every meeting, but I mean, the fact that we have just treat dementia like it's something out there that doesn't belong in traditional healthcare or in behavioral healthcare, and it just sits there. And the brain's part of who we are. And I know Natalie talks a lot about, you know, early detection. People are scared of it. I think we have frightened healthcare providers afraid of it too. And it's so important if we're going to use the new drugs on some of this. we got to get out there and kind of work on this, but this is really important. And I think the fact that we kind of sit here at FSSA and don't have the healthcare side, that just,
yeah,
you got to bring it together or we're not going to get there. And I think that's what this particular initiative talks to us about, the need for whether we call it whole person care or integrative or comprehensive, or I don't know the best word for it, but
right.
Yesterday I had a presentation with traditional age college students in a gerontology course, and I said we were talking about policy, which usually puts them to sleep at those ages, but I asked them, think ahead when you're 100 years old, and I was kind of stunned. Those students said, I'll be 100 in 2103. Into the next century, and all we're doing here with policies. And they looked at me and they said, I said, I'm right at the top of the baby boomers. And they said, wow, there sure are a lot of you. and that's true. And so what we're doing now with these policies really will be helpful for many, many years as we start to address some of these issues. But dementias are like the big elephant in the room. And even in we have Q source here today with the QIO. The federal government's afraid to put some things about dementias in their scope of work. It's so enormous, whether you're in institutional care or you're talking about home community-based services. So this is such an important part of the work we need to be doing going forward in aging in Indiana. So we're making strides. We're starting to address issues with family caregivers and so forth, but we really do have to help our healthcare providers come on board here with us. And that's the integration of social care, behavioral health, and now my question is, where's behavioral health in all of this we talked about? I don't know. I'd like to hear from the advisory group a little bit of, do we need to include behavioral health more in this? I never did understand, since we have trouble with, I mean, it's the brain, where are our behavioral health people? Any comments from anybody?
You've dumbfounded them, Dr. Burke.
Well, I would agree.
I just put in the chat there, and Shannon, you might want to make a comment about the new guide model that CMS has announced just recently and coming out, or I'd be happy to do that if you'd like.
Well, I can start and feel free to chime in. So CMS, so the Centers for Medicare and Medicaid Innovation has released that they're going to be pursuing a demonstration project, which means they're going to be testing out payment for certain services and to see if it's effective or not. So they're going to be testing collaborative care models tied to dementia. So supporting not only the person with dementia, but their caregivers. And this is really exciting because as part of IU, our aging brain care, which Dr. Council has been speaking about at the community-based model, this is work that's been going on for 15 years. We have the Aging Brain Center at Eskenazi, and our IU faculty developed that model. And we are one of, I believe, 5 or 6 in the nation that CMS is working directly with as they designed what is this demonstration going to look like. And so providers, you can do it. There are 3 different ways that you can apply to receive reimbursement. There are 3 different structures, and I won't get into those details and bore you with those, but they can be pretty innovative. So for example, a AAA could partner with a geriatrician to deliver that. A healthcare professional needs to be part of it, but it could be a more community-based model. So it'll be really exciting to see who does apply for this and test it out to see if it's effective. We believe it's effective. We know it's effective, right? And so it's taken CMS a while to get on board with that, but we're really excited. And IU has funds through the Hartford Foundation to start making sure we have the infrastructure, because we're going to start being inundated. We've already heard from UNC. IU Health wants to do this. Eskenazi is already doing it. We're going to start to receive a lot of interest from different entities who are going to want to implement our model. So rather than developing a new model, they say, wow, ABC really works. We just want you to help us do ABC where we are. So we're super excited about that. But anything you want to add, Steve?
Oh, I'll just give you the acronym is Guiding an Improved Dementia Experience Model Guide. And it comes down to 2 core activities by a healthcare professional and a care navigator or a care coach, similar to what we've been doing under the ACL grant. But it's a combination of both the healthcare and the caregiver collaboration. And it has 2 roles: one to collaborate, to coordinate care, so the healthcare side, but also then have a role to support and train caregivers in their role. And this is family informal caregivers. So it's right on track. We're out ahead in Indiana on this, and should be a big part, as Shannon has mentioned, in the future.
Yeah. Yeah.
That's really good news.
Mm-hmm.
That's very, very good news for Indiana as far as I'm concerned.
Guided, improved.
It's called GUIDE for short. That's an acronym. And Steve, you'll have to say what it stands for again.
Guiding an Improved Dementia Experience. Guiding an Improved Dementia Experience. And that's directed, as our work has been, around both the person living with dementia and their caregiver.
Yeah. Okay.
We could send out the fact sheet potentially after the meeting if people are interested.
I would be very interested in that, Steve. Please send it out. That's something to be really excited about here.
Yeah, and CMS is coming out next week to do a site visit with us at Eskenazi, and again, further learn more about how we implement ABC there. So that's exciting. All right, any further thoughts on Dr. Burke's question related to how does behavioral health intersect with this? So I think the first piece, it is kind of tied to education, but it's making sure that people understand the differences. So I just conducted a training yesterday with adult protective service workers across the state of Indiana, training them on the aging process. And one chunk of that was learning the differences between depression, dementia, and delirium, because there are symptoms that can look very similar across those 3. And how does someone who's got very limited time and interaction with someone really help to discern what they might be struggling with at that time? So I think that I'm not a behavioral health professional, so I can't speak to exactly how they may interface with that on a daily basis. But in a lot of our work, I know that it can be a struggle for just purely identifying what is somebody struggling with, or is it depression and dementia? What's going on there? But I do think it's something for our steering committee to consider adding behavioral health entities to this group. I mean, I could go on and on. I mean, suicide is extremely high in older adults. They're extremely effective at executing suicide. And I think it's a great suggestion to consider adding them to behavioral health to this group.
Well, and we've had a problem with antipsychotics being used, overused with this population. So
yeah,
that's why I bring up behavioral health.
Yeah.
And people, sometimes get in the behavioral health arena, and how well are we diagnosing and detecting dementias? Right. They get treated for the wrong thing, or they'll just be called, it'll be called a dementia when they're depressed. I mean, we got, right. I kind of like just raise the question of bringing in some behavioral health folks.
I think it's fabulous. And I sometimes, you know, when you are depressed, it does affect the brain and it does affect short-term memory. And then that, to your point, could be confused as dementia.
And then the other, I don't even know, I guess I'll say it, delirium is a real problem. Age-friendly hospitals. I got into some of that, and the care in hospitals and delirium is huge. Great big problem with older adults in those settings. And then they're discharged.
Right.
And they're not doing well. So I don't know. I think some of those folks might be somebody to consider bringing in here too, in those care transitions from acute care settings into either they're sent home or they're sent to nursing homes, and people don't just snap out of delirium quickly. You would think, well, maybe they are as soon as their infection's down or something, but it takes a while.
Right.
So
yeah,
that out to the consideration.
I am very thankful that you guys are adding the caregivers to this. I took care of my dad, and when you see your father go from this big, strong, mighty hero man to a broken person who's looking to you for answers, it really does screw up your head.
Yes.
I would just add to Judith's comment, one thing that we have talked about at the steering committee, and we just haven't really settled on the appropriate way to do this yet, is making sure that we have active caregivers and people living with the disease as a sounding board for some of our future recommendations and implementation. So I know that we'll be continuing that discussion as a steering committee, but we want to make sure that the recommendations that we're developing work for the people they're intended to help. And this work as a state dementia strategic plan is not just about those living with dementia who are participating in some of the services and government programs that are administered by FSSA, but it's really meant to be for all Hoosiers who are impacted by dementia or caregiving, both now and in the future, right? So we have a lot of Hoosiers who have not been diagnosed, who might be living with dementia, people who might be caregiving for someone without a diagnosis, people at all different socioeconomic and diversity, you know, in our communities, who should benefit from the work we're doing with this strategic plan.
Yes, thank you for pointing it out, Natalie. I mean, a lot of what comes out in our discussions here at the Commission on Aging, you know, is tied to a lot of the services that FSSA provides, but this work is really for all and any Hoosiers across the state. Okay, well, I really, you know, if you think of anyone else, you want to talk with me, get coffee, whatever, please reach out. So my email is seffler@iu.edu, and love to connect with you and talk more about the work we're doing.
Well, thank you so much. This really is important work. And as that student said to me yesterday, there sure are a lot of people. So, so this will impact a lot of people. Thank you so much.
Thank you for having me.
Okay. We now will get some advisory committee reports from the advisory committees on the Commission on Aging. On the Living Longer, Living Better Collaborative, we do have a meeting coming up in rural Tipton County next week on 211, 911, and 988, because people did not know when to call, who to call. They didn't understand the programs. And that's just one of the local initiatives that some of the collaboratives are doing. I know across the state, we have many collaboratives going that have integrated issues related to older adults into their work. And I think some of these collaboratives, I know they address all types of issues in the communities and have added the older adults. But I think there's a lot of confusion around. People don't know who to call and what services they might get from these. So that's something that's happening up there. And I know the collaboratives continue to work across the state. Judith, do you have something to share from the shared decision-making committee?
We do not. We are trying to work on getting CASAs into the courts for guardianship. That's proving to be a little bit of a challenge for us. So we're still working on it though.
Okay, thank you. Jennifer, I think you're giving us an update on emergency housing. I kind of touched on housing this morning. So what do we have going with emergency housing?
Deb is doing a great job leading this group. There has been a lot of progress, I think, on it. There is a scope of work agreement that has been sent out to APS, who is looking to fund a designated number of groups for pilots to do this. Deb's site is one of them, and we're trying to identify some different sites across the state that could pilot this program. Additionally, from that, we are working on policies and procedures. So when we go to a new site and say, hey, would you be willing to do this? We can give them kind of a guide or a handbook or what's expected. If you're going to be an emergency housing site, what does that look like? What are kind of the parameters of that? So once that guidebook is kind of put together, I know that's the point where Deb was going to bring that back to the commission, have everyone take a look at that and kind of be able to give progress of how soon we're able to really kick off this pilot.
Okay, thank you. The Family Caregiving Advisory Committee did meet with Darcy Towers, a group that's working on messaging for the Pathways program in Indiana, and thanked the committee and invited any more comments we might have to help them as they put this messaging out in various formats across the state. This committee will continue to meet. There was quite a bit that came out with supporting family caregivers from the presentation on the strategic plan. I'm sure we'll take a look at that. Currently, I'm leading that, and I think I'm trying to get another commissioner taking this on. I think we will have that done very shortly. Housing supports, Dan is not on our meeting today. And,
I could give a quick update on that one as well.
Okay, Jennifer.
We've had a lot of meetings. Dan has pulled together a really diverse group. We've had endless discussions about housing in Indiana. It is a massive topic. But currently what's happening is Dan is pulling together kind of the notes, categorizing into groups and pulling together. I think what we decided is just to bring back some recommendations to the commission on kind of next steps or things that should be looked at. It's certainly not a topic we can solve in this group, but I think we'll be able to bring back a really good summary of core issues and some recommendations that can be looked at. So I know Dan is working on that as our next step.
Thank you. And Leslie, you're still here. You mentioned that there is an initiative going forward in this coming year to do some work with IHCDA around some of these issues. Could you just...
Yes, so IHCDA is in the midst of doing a housing feasibility study that we funded using the HCBS federal funds. They are several months into the project at this point. So in I can't remember the exact timeline on when we'll be receiving the results and recommendations from that report, but sometime in the next handful of months, we'll receive a report on that feasibility study and what they found for gaps for senior housing across the state. And they can use that to sort of develop additional recommendations and paths on what we and other agencies can do to address the housing needs of older adults around the state.
Okay, thank you. And the Senior Center Coalition of Indiana, Dan not being here, we will not have an update on that. And Kristen, Kristen's here. Hi, Kristen, I couldn't see you because I had this block fixed. Glad you're here, and we'll hear the I-4E update. You have 20 minutes.
Embarrassment of riches here. Oh my gosh. Hi, everybody. I was at the Indiana 211 Advisory Committee meeting, which was happening at the same time. So I did theirs first and cut out from there early. So apologize for coming in late. I want to follow up on your question about mental health and behavioral health. We also want to remember that the Division of Mental Health has a new aging czar, Rena, Catherine Kate Hager. And so she corralled money for some initiatives, and there are a number of AAAs that were funded under that. I don't know that it is necessarily coordinated with the dementia work, but that is something that is being addressed and in cooperation with the Division of Aging and the AAAs.
Thank you.
Yeah. Okay. I asked Julie, I sent this, the packet to Julie. I don't know, is she out this week?
No, she's here.
Oh, okay. Did everybody receive their packet? No? Okay.
No.
Okay, all right. Well, you're going to get a big one because apparently everybody did a lot of work in August and September. So, so I'm going to talk through what we've got in the packet. And we'll start with the fact that, hey, it's flu season shot time. And that's kind of at the top of your packet in terms of the recommendations around flu, COVID, and now RSV. Vaccines being available. The new COVID vaccine was approved a couple weeks ago, and it is already in pharmacies. I got my flu shot and COVID shot yesterday, and so far so good. Or no, Tuesday. So far so good. Just a little bit of soreness in the arms, but you know how some people, sometimes depending on the formulation, it can make you feel really awful. So kind of thankful for that. So the first part of your packet just kind of updates you on the COVID vaccines and a couple of articles in there. There was an announcement just yesterday that the US is going to be offering free at-home COVID tests again through the post office. That registration starts Monday. And I think the email address or the website address is covidtests.org. No, gov, G-O-V, covidtests.gov. September, I think if you have some kind of annual recognition, more than not, likely than not, it happens in September because all of a sudden it's month this and week that. So Dan might be celebrating National Senior Center Month. So there's a, and the NCOA, National Council on Aging, does a lot of work around senior center support and evidence-based healthy aging programming. And so there's a packet in there. There's some information there for you on that. In addition, it is September has Fall Prevention Week. So that will be another thing that people can amplify. And again, NCOA has a lot of the information on that. There was also a new report that came out from Morbidity and Mortality Weekly that analyzed non-fatal and fatal falls among adults aged older than 65 years, 65 or older in 20 and 21. It does have state-specific data. But just because the packet was getting so big, I left out the state charts. But you can find the report if you're interested in Indiana's data. I think there was one that we were doing slightly better than average, and then another piece of data that Indiana was doing less than average. But it wasn't abysmal on either end. September is also Emergency Preparedness Month. And this year, the FEMA themed their month around older adult preparedness. And the Department of Homeland Security here reached out to me. I learned they publish a Hoosier Responder magazine. Who knew? With a circulation of about like 50,000 people of all sorts, including just individual citizens, as well as emergency response professionals and other kinds of, first responders and community partners, et cetera. And they asked to interview me around older adult preparedness. Well, it's not something I deal with every day, so I had to do my own research. And there's a lot out there connected with FEMA and ACL. Both have on their websites a lot of resources related to older adult preparedness, disability, persons with disability preparedness, pet preparedness, which is really important because people, I wouldn't leave without my pets, so I know everybody else feels that same way. So there's kind of 3 levels that I was able to discern. There's a focus on how do you help individuals be prepared, individual preparedness. And one of the discussions we might consider is how embedded that individual preparedness is as part of our care planning processes. Is it ad hoc when there's a care manager recognizes something, or is there something that is driven in the care planning process to automatically address it? So that might be one discussion for the future. Another area is community preparedness. We did a little mini quiz in our board meeting in September, and we're asking, hey, how are AAAs involved in community preparedness? And it ranged from, hey, we talk regularly with our emergency preparedness people in our local communities, or we participate in exercises with our community, or we regularly provide names of clients who first responders and emergency preparedness people should know about in case of an emergency or a need to check on. So there seemed to be a lot of good connection in the AAA network, at least, with those emergency preparedness professionals in local communities. And the final bit of it was business continuity, both in terms of how do you just keep your AAA operation going, or how do you keep your social service or community-based organization going in an emergency, but also how does your organization proactively respond and inform clients and check in on clients when those preparedness issues affect them are coming down the pipeline. And so it was just some really interesting things to delve into and to think about how our networks respond to that. Nationally, of course, because it's a national recognition month, there are things happening with FEMA and ACL. I was talking with a colleague on the West Coast who their ACL and FEMA regional administrators are trying to work on a formal collaboration, and some of their AAAs and state agencies and stuff are involved with all that. So that was kind of interesting to hear about too. So there's stuff in your packet about emergency preparedness. The other thing I want to point out is there are also articles in there that showed up this month with the heat waves we've had about the impact of extreme heat on older adults specifically, but the fact that it affects everybody and a lot of workers and all that kind of stuff. So that'll be something we want to pay attention to in the future, since those extreme heat events are going to be more and more likely. Division of Aging sent out a notice that we are in the midst of Malnutrition Awareness Week. The governor's office proclaimed it Malnutrition Awareness Week, and the Division of Aging shared that connection with nutrition risk for older adults and provided some resources around that. So those are kind of all the fun things that you can consider amplifying with the publics that you engage with. And then there was like a big slew of things happening in federal policy land. And some of this is happening because we're getting near the end of the Biden administration, and all the executive agencies want to get their stuff done before there's the possibility of a new administration coming in. So we saw like a boatload of proposed rules come out for comment from ACL and from CMS. And you know, there was one on APS, and it seems like each week there's a new call for public comment. So I'm gonna just highlight some of those for you. You heard the news that Medicare is going to be, has named the drugs they're going to be negotiating prices on with the drug companies, the list of 10, and there's an article from Kaiser Family Foundation in there on that. There was a rule, excuse me, that is my phone. I thought I turned it off. I'll just let it go. The Centers for CMS issued a rule around minimum staffing standards and for long-term care facilities and Medicaid institutional payment transparency reporting. So these are kind of like the third rails that the nursing home industry wants to avoid. But the Biden administration really wants to try to put in place those minimum staffing standards, as well as address the intergovernmental transfer program, which we saw a lot of reporting on last year and the year before by the Indianapolis Star. So that's kind of how it affects us locally. And so there are some articles in there on that, particularly from CMS, just the notice about what that report or what that rule is about, and a couple articles from Kaiser Family Foundation about how that might affect nursing facilities and long-term services and supports. Biden administration also announced new actions to lower healthcare costs and protect consumers from scam insurance plans and junk fees. So there's going to be some of that involves Medicare Advantage marketing. So there's something in there on that. I talked with you previously about the proposed rule that was out for comment on Older Americans Act, and I included the response our National Association made to those rules, and those were some of the things that our own AAAs would concur with. Let's see, what else have we got here? There was also a, this happens, I think annually, a proposed rule for the calendar year 24 physician fee schedule coming out of CMS, I think primarily for Medicare. The thing that was in there had to do with questions that might involve ways to pay for social care management, which was new. And so our national, we kind of flagged it for our National Association. They submitted comments, and some of the things, it seemed a lot to be focused like within a physician practice or within a Medicare provider. And so we already have ways or initiatives in which community-based organizations can subcontract with physician practices or payers under some Medicare initiatives. This seems to expand that. And we also commented on the ability of CBOs to potentially bill for that without being within that physician office or subcontracted to a Medicare provider. So how could CBOs become Medicare providers just for these services in their own right? Okay. Elder Justice Reauthorization and Modernization Act of 2023. So that was another thing that was floated. The reauthorization is out there. It's not likely to pass. It doesn't mean the little bit of money that's already coming through for elder justice from ACL is at risk if this doesn't pass, but it really tries to strengthen APS and elder justice kinds of things. So there's an article in there, a couple articles in there for you about that, if you have an interest in that. There were also articles related to how the fact that all the things we enjoyed as part of the pandemic flexibilities and the extra money coming in that helps support home and community-based services, how with that going away, some of the implications of that for home and community-based services are in there. Okay, I think that's a lot of it from federal land. To your point about mental health, there was an analysis from Kaiser Family Foundation. I'm glad I put it in there because it was so big. I thought about not putting it in. They took a look at 988 suicide and crisis lifeline implementation 1 year after launch. So it's not focused specifically on older adults, but it's certainly a resource that deals with mental health. There's also an article in there that disproves the woodwork effect if states expand Medicaid HCBS. So that was kind of a, a good support for expanding that. There was also a big section on housing, which of course continues to be an issue nationally. And one of the bigger parts of the packet includes a analysis or guide or set of policy proposals that AARP has made, their Public Policy Institute has made around housing. And so I thought it would be a good resource for inclusion with the discussion this group has been having. So all that is in there, and that's probably that much of the packet. A couple other articles about housing. Another thing that came out in the press was research about the ability of this generation of retirees to actually retire. And so there was research that came about. There were several articles. There was bringing it down to the local level from Axios Indianapolis, as well as some national articles that were responding to the research, and really gets to some of the need for states and the federal government to continue to work on not only LTSS financing reforms, but also enabling more older adults to save for retirement. And some states are doing that with state-sponsored retirement plans, where if you work for an employer that doesn't offer one, you can join the state's plan. The state's not providing match for it, but at least it gives you a vehicle that you may not have had access to otherwise. So there are some ways that that's being addressed. Other states are actually offering a long-term services and support savings plan, or kind of a, in some way, state supported long-term care insurance, as opposed to getting it off the commercial markets where it's just, extraordinarily expensive. But those really look at the ability of, those require contributions from individuals, actually paycheck deductions in cooperation with employers. And then the state helps to manage that kind of savings and offers a benefit based on how long you've been contributing. So
I think the state of Washington.
Yeah, like Washington and Oregon, I think both have some of those. Final thing that came out, there's several articles in there. The scope of elder financial exploitation, what it costs victims, came out from AARP during this time period, as well as some additional articles on financial exploitation and scams affecting older adults. And I think that just a couple other miscellaneous things in there. I do want to point out that, or highlight that AARP next week will be releasing their updated LTSS scorecard. which happens every 3 years, I think, on their cycle. So that will be something we all want to keep our eyes on, and hopefully, got some thoughts. Maybe Indianapolis will, or Indiana will improve their standing. They're apparently have reconfigured some of the way they look at things, and are also taking into effects of the pandemic. So that was kind of in their pre-release notes. If you go to the LTSS scorecard website, there's a big banner that says, hey, it's coming this last week, September 27th or something like that. And it has some discussion about what will be different in the future. And finally, I couldn't resist throwing this in there. The last article in your packet talks about the fact that having a little more weight on you when you're older isn't quite such a bad thing. So I thought we all could appreciate that. Is your that is something I think we all can relate to and can feel a little bit good about, but I just thought you all might get a chuckle. So that's what we've got going on. And of course, especially related to all the public comment stuff that's out there, we are paying attention to it and in communication with our national association on it. Sometimes we just don't have the capacity to come up with our own separate public comment, but we do have the opportunity to inform our national associations who do surveys or phone calls or things like that. So we are playing a role in that. It just may not be so direct.
Well, Kristen, thank you so much. It's always, you always bring us really good information and keep us current on many things. So thank you so very much.
Thank you.
Well, it is about 2 minutes past 12. So we've covered a lot of content today. Thank you to all our presenters. It was wonderful to get the dementia state plan update. And we look forward to having you back to continue to work with us on that. Thank you to the Division of Aging. So we will, if there's no further business, I will adjourn the meeting and we'll see you in November. Yes.